In looking at this topic and what I would talk about, I thought about what was important to discuss, and I thought I would talk about errors in the ICU. I think a lot of you have heard about this. I'll talk a little bit more about this very briefly, but more so talk about various ICU treatments that most intensivists sitting in the audience take for granted, things that we have been doing for years, and things that we learned in medical school as residents, as attendings, that this is the way we do things. And yet, if you look through the literature over the last several years, there have been major changes in the way we do things. And in looking at the issue of safety, I thought I would talk about the ultimate safety, studies that show an improvement in survival or increases in mortality, because that's a crude endpoint that we can find very easily. So if we're looking, per se, at treatments, how do we go to a patient, or in the ICU, more likely the patient's family, to get informed consent to put half of the patients on a placebo, when intuitively we have this drug that seems like it works, and why wouldn't we just give the drug to the patient, to all the patients, as opposed to giving half the patients placebo?
I shall divide my group into two halves. To one, I shall give injections of our serum. I shall deprive the other half of any injections whatsoever. I shall then watch which half resists the plague more successfully. When I have done that, I shall know what our serum is worth.
Good heavens, why? The man Order. I can handle this. Order. Do you mean to say you can't find any other way to test your serum?
Well, there is no other way.
You call yourself a doctor and want to see half your patients die?
Oh, no, sir, no. The uninjected half will be fully as well taken care of as they are at present.
You actually propose using the inhabitants of this island as you use guinea pigs in your laboratories?
Well, you put it unpleasantly, Sir Robert, but that is what I do precisely propose, and for precisely the same benefit to mankind.
Well...
So, Dr. Arrowsmith had some problems convincing the members of his island to have the inhabitants participate in a randomized trial, but let's look at some of the problems and treatments. So here you've heard the paper from Yoel Duncan that came from our unit in Jerusalem. I just happened to move to Jerusalem at the time. I was an American physician and thinking about doing a study like this in the United States, where we're identifying errors, certainly coming from the University of Miami with the largest contingent of attorneys per capita, was something that would never happen. But interestingly, looking at various activities and the distribution of errors, you can see that the nurses spend a whole lot more time doing things than the doctors. The errors are pretty much similar, but despite the not performing as much activities for the doctors, we physicians make a whole lot more mistakes. And interestingly, you will see some of these mistakes immediately, but sometimes you'll see the mistakes, you'll discover these errors not immediately, but perhaps a few hours after rounds, or when changes are made after changings of shifts, as you can see here. So in fact, there were many errors that were identified, and there were potential fatal errors occurring twice a day in our ICU. Now, thanks to Yoel, we had some sophisticated human engineers. We have a new order sheet, nothing like you saw at John Daniel's unit, and we have a new charting system, and things have improved. But what about the ICU? Now, most intensivists consider, and actually not just intensivists, but I think most patients and families assume that the ICU saves patients, and we clearly believe that. How can you be an intensivist and not believe that? So we did a study a few years ago. This was a prevalence study looking at 5 Israeli hospitals, 4 evaluations, 2 in the summer and 2 in the winter, and determination of the first day the patient met prospectively defined criteria to be in an ICU, and then we followed those patients for 30 days. And interestingly enough, there was in fact an improvement in survival in those patients who were in ICUs compared to those on the ward. Interestingly enough, it was most interesting that a lot of the patients on ventilators or even on vasopressors left the hospital from the wards. So you didn't necessarily always have to be in the intensive care unit. There are many countries that require ventilated patients to be in an ICU. Half of our ventilated patients in our country are in medical or surgical wards. So we don't have the luxury of that many ICU beds. And in fact, a lot of ventilated patients are on the wards and they survive. Interestingly, though, the major benefit of the ICU was in the first 3 days. And after the first 3 days, there didn't seem to be that much of a benefit. Now, after a while, it may be good to be in the intensive care unit for a few days, but after the patient is improved, the ICU can be a dangerous place in terms of an increased risk of infection. Not only infections with typical organisms, but resistant organisms. So ICUs do improve survival, but not in all patients, and the major benefit seems to be early on. Now, it's hard to talk about ICUs and infections without talking about the Peter Pronovost study, which was mentioned earlier. And the bottom line was that an intervention with looking at several patient safety interventions could actually decrease bacteremias to 0. And these were a sustained reduction that were retained. And it's very hard sometimes to make a change, affect that change, and to maintain that change. Now, for most intensivists, this is sort of bread and butter, but I think we have to think about what we see on a daily basis. I can't talk about all the changes, but I'll just talk about a few. Low tidal volumes, the ARDS network, looking at 6 milliliters per kilogram as opposed to 12 milliliters per kilogram, which was used for many, many years by many intensivists. Interestingly enough, still used even after the paper was published, showing a much lower mortality in those patients using the lower tidal volume. Blood administration. I remember being a student, a resident, an attending physician, and most patients in an ICU whose hemoglobin dropped below 10 got blood. Till we saw the Canadian study from Paul Hebert showing that looking at a trigger of 7 as opposed to 10 could make a difference, not in the overall strategy of patients, but in those patients less than 55, there was a higher survival in those patients not getting that much blood, a more restrictive policy. And if we look at some of the complications in terms of safety, in those patients who got less blood, there were less myocardial infarction and ARDS, and a trend towards patients with pulmonary edema. Insulin. Many of us in ICUs were taking care of many patients with very, very high glucose levels, glucoses of 180, 190 milligrams per deciliter, or many times when you did a computer search of all your glucose levels on all your ICUs for a period of a few weeks, some of them were actually more than 200. And the Leuven group showed that intensive insulin therapy, keeping glucose levels in the range of 80 to 110, as opposed to a control group in those patients who had high glucoses, greater than 215, and then keeping those levels between 180 and 200, was able to improve survival, especially in those patients who were in the ICU for several days. Interestingly enough, a recent study, the Nice Sugar study, looking at a different control group, the intensive insulin group is pretty much the same, but their trigger was not a high level of 215, but rather keeping the glucose levels, if the trigger was 180, keeping those levels below that, had a higher survival in those patients who had the less aggressive insulin therapy.